Let's talk about what sort of tests should be done following an MPN diagnosis. Can you tell me about those?
Yeah, I think, fundamental to the MPN itself, one of the things that we really want to know is, in most cases, a bone marrow examination is needed because that will tell us really what the disease is that we're dealing with. It will tell us about the genetics. And I strongly believe we need to be comprehensive in our genetic assessments because that does prognosticate and sometimes gives us a opportunity in terms of treatment. Chromosomal analysis. These are kind of the basic bread and butter hematology tests we want to do from the bone marrow to really understand what the patient's disease is. Beyond that, I think that particularly in patients with PV and ET, it's important that we partner with their primary care physicians to make sure that they've had, for example, testing for diabetes, a recent lipid profile, any cardiovascular tests, particularly measurements of blood pressure, because these things are all important in terms of a ET or PV patient's risk of having a blood clot. So there are, again, things that are within the hematology realm, but then there are other general health things that become really important in somebody who's diagnosed with PV or ET.
Yeah. How often should lab tests or blood work be done?
Really depends on the patient. And for some patients with PV, for example, they need to have their blood checked every 3 weeks because they're having frequent phlebotomies, whereas some patients with ET could probably go 4 to 6 months between blood tests. So it depends on the individual.
Mm. How can results of biomarker testing affect treatment choices for patients with MPNs?
Great question. The genetics are becoming increasingly important in our treatment decisions. So let's take a simple example, which is patients with ET. Calreticulin and JAK2 and MPL-MIPL are the 3 most common mutations that we see, but they have very different implications. So somebody could have a calreticulin mutated ET, and based on them having that calreticulin mutation and no other factors like no history of clotting, that patient may never need to go on a medication aside from aspirin. And even early on, it's debatable whether or not some of these patients really need aspirin at all. Whereas somebody who has a JAK2 mutant ET, our guidelines and data suggest that person, once they reach a certain age, should probably be on medication. So that's kind of perhaps one of our more clear-cut examples of a genetic biomarker telling us, how to approach treatment. And then it gets more nuanced from that and more exciting and interesting in the sense that there are mutations, for example, that occur in myelofibrosis and in patients whose disease is progressing towards leukemia, such as IDH mutations. And these are things that are now targetable with FDA-approved drugs. And there are now clinical trials combining JAK inhibitors and IDH inhibitors for patients who have more advanced disease who have these IDH mutations. So you go from, on one end, these genomic markers being of prognostic significance, and now on the other hand, we're getting to a point where in some cases, they might tell us how to best treat a patient.
Dr. Rampal, should all patients diagnosed with MPNs undergo molecular testing?
I strongly believe that. I think that we've learned so much that these tests have prognostic value, and in some cases may suggest a slightly different diagnosis. I definitely think that should be the case.
Mm. What should patients be asking once they have the results?
What does it mean? That's the most basic and fundamental question, right? It's one thing to get a list of mutations, but the real bread and butter question is, what does this mean for my disease and my prognosis and my treatment? Those are the key questions.